Well, hello everyone and good afternoon. I'm delighted to welcome you to one of the great occasions in the college calendar. We have 3 eponymous lectures at the college, the James MacKenzie, the Pickles Lecture and the John Hunt. Some people say that the James MacKenzie Lecture is the most important one. So for today's purposes, you can take that as a given. But and I'm delighted to say that the lecturer this year is Professor Tom Fahey. Tom is the Professor of General Practice at the Royal College of Surgeons in Ireland, at the Medical School in Dublin. He has held some very important and significant roles in the Irish Health Service. You'll see that cited in the booklet that you have before you. His research focuses on vulnerable groups, elderly patients, children, pregnant women, and drug users. He also has done work on clinical prediction rules in general practice and computer-based decision support. I've had the privilege of previewing Tom's lecture, and I think we're in for a real treat once again. Tom's history is just absolutely amazing. I mean, he qualified at UCD, University College Dublin, in 1986. He trained at Oxford. He's held academic positions in Oxford, Bristol, and Dundee. He's won numerous prizes, including the college's John Fry Award, which is for younger researchers, and he's also worked in Canada. So he's published more than 220 peer-reviewed papers and has held and is holding a number of distinguished editorial positions. He also hosts a number of professorial fellows, the Fulbright Fellows from the US in his department, including European exchanges. He lives in Dublin with his wife Deirdre, who is here today. She's a professor of obstetrics in Trinity College Dublin. Tom tells us that they have 3 adult children and 2 juvenile dogs. Tom, can you please join me on the stage now?
President, members of college, fellows and members and colleagues, thank you very much for the kind citation, and thank you very much for the honour of giving the 2019 James MacKenzie Lecture. I'm going to talk about why evidence still matters to general practice. I'm going to make the presumption and quote from James MacKenzie because I hope, I'm going to make the case to you that I think MacKenzie would also agree that evidence still matters in general practice. He was a prolific author, as you know, but I'm going to cite 3 main works, which are all from the BMJ. One on appendicitis. The second one there is on clinical research, and that was given at the establishment of the Institute of Clinical Research, in St Andrews in 1919. So the first 2 are more summaries of James MacKenzie's life and work. Why evidence matters, I'm going to talk across 3 main themes. First of all, evidence in terms of integration with patients' decision-making. Secondly, the importance of evidence in terms of clinical observation. And then thirdly, the importance of evidence in relation to a systematic approach to clinical care. Before I do so, I'd like to acknowledge my colleagues in Dublin. My colleague Tom O'Dowd from Trinity College is here today, so thank you very much, Tom. But I've got many other collaborators over the years from Oxford, Bristol, Dundee, who also contributed to this work. And I'd also like to acknowledge the funding of the Health Research Board of Ireland, who've funded our research centre for the last 11 years. So to start on the first domain or area, it's in relation to integration with patients' decision-making. So this is a slide from the New England Journal of Medicine from about 5 years ago. And on the right-hand side there, you can see the highlights in terms of drug development over the last 50, 60 years. And these would be all well known to us as clinicians. There's been a huge improvement in the therapeutic array of drugs that we can give to our patients. Not only that, but in terms of medical devices, again, a huge improvement and change over the last 75 years since Mackenzie's death. But what I want to also highlight to you is this other column, which is about the changes in research methodology since Mackenzie's time. And as you can see, in the 1940s, there was the advent of the randomized controlled trial. But going into the 1960s and 70s, not only design and not only improvements in research design changed and improved over that time, but also the whole analytical approach to randomized trials and observational research improved as well. And then in the 1980s, the McMaster University implemented evidence-based practice, and I'm going to talk a little bit more about that now. So Mackenzie was prescient in saying that those engaged in medical research should pause and consider what they're doing and be certain that their methods are suited to their purpose. So to reintroduce you to the concepts of evidence-based medicine, it's the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. So it's firmly rooted in clinical care. The steps are asking the clinical or research question, accessing evidence, appraising that evidence to assess its validity, usually its internal validity in relation to the study design, and then applying that evidence to an individual patient, very often making judgments about the external validity of that evidence. So since Mackenzie's time, we can see that structuring the research or clinical question, I'm using an example of a therapeutic question here. The PICO format, patient intervention, comparison group, and outcome, is the first starting point. Then we think about the domain. In this instance, it's a therapeutic domain, so the best form of evidence would come from randomized controlled trials. This is a slide I use in our postgraduate teaching, and it highlights on the right-hand side the strengths of the randomized controlled trial. High levels of internal validity, but limited in terms of its external validity. On the left-hand side, then, you can see the other forms of research evidence that pertain to issues around prognosis, diagnostic accuracy, etiology, and harm. And by necessity, these types of study design, the case control study, the cohort study, or the cross-sectional study, are the most suitable types of study design to answer those types of clinical inquiry. However, we now appreciate that actually the risk of bias in terms of the internal validity of these studies is greater than the randomized controlled trial. However, of course, the external applicability of that kind of evidence is far higher than the randomized trial. So just to summarize, that we are very much aware of a hierarchy of evidence in terms of validity, and this has been a huge improvement in terms of making judgments about evidence since Mackenzie's time. So why is this important? Well, integrating evidence into clinical care is a necessary practice, but it's certainly not sufficient. And this is probably my most favourite slide of all, because it shows, as practicing clinicians, we need to consider three things. First of all, at the bottom there, you can see the external evidence. But on the right-hand side, it's one's own clinical expertise and experience that comes from your training, both at an undergraduate and postgraduate level, and as you proceed throughout your clinical career. But on the other side, of course, in terms of improving patient outcome, is trying to assess and integrate patients' values and expectations about treatment. Why do I think this is important? So the first example I want to give you is in relation to hypertension, a very common condition that we deal with in primary care. And I started out my research career in relation to my research centering principally on hypertension. And this is a Lancet editorial over the summer, which highlights or is commenting on the recent NICE guidelines in relation to thresholds of treatment for initiating treatment. And you can see that they are saying that the threshold of 140 over 90 millimeters of mercury and an absolute risk of 10% over 10 years, they're approving that as a threshold for treatment. But what piqued my curiosity was they were saying also, maybe if they lowered the threshold to 120 millimeters systolic and a 10% or higher threshold of absolute risk, it would show, as they say here, true grit. So what does that mean? To me, that means that they are making their own judgments about patients' values about the threshold of treatment and indeed the cost effectiveness of that treatment. So when I started out my research career in Oxford in the early 90s and then moved to Bristol, we were very interested in prognostic risk in relation to hypertension. And this is the Framingham risk function, probably the first of many risk functions that are there now. And we were looking at the validity of applying that risk function and the agreement between hypertension guidelines in relation to estimation of cardiovascular risk. However, after a few years, I quickly came to realize, of course, that one's own perception of risk is a very personal and individual thing. And so we then did a randomized controlled trial in Bristol practices where we tried to incorporate that other dimension, that dimension around patients' values and preferences. And my colleagues, Alan Montgomery and Tim Peters, were my colleagues on this piece of work. And what we did was we developed a decision aid for patients who were facing a true treatment decision about whether they should start blood pressure lowering treatment or not. We did this in a very quantifiable way in relation to both the prognostic risk score for cardiovascular events, but also quantifying their preferences. How did we do that? Well, we did it through a process known as decision analysis. So this is a process which incorporates and quantifies people's risk of a cardiovascular event with the value they place on the health states that are consequent of either accepting or declining blood pressure lowering drugs. We assessed the values of how people felt about health states using a utility assessment measure called the time trade-off method. I'll explain that to you in a moment. And this was all done with a piece of software that the patient sat in front of, where they estimated health states, and then they were given a recommendation based on their own individualized risk and their preferences about treatment as a form of shared decision-making for the patient. So this is the simplified decision tree we had in the study, and you can see on the right-hand side, as you look at the graph, is the decision tree, whether you take blood pressure-lowering drugs or not. These round chance nodes are the estimates of probability, both in terms of cardiovascular risk, but also in terms of the likelihood of side effects and the consequences of having a stroke or a heart attack, whether you're severely or not so severely affected. So you can see, I'll just give you an example of how we estimate people's values in relation to that one state of health. So that's somebody who's been treated, who gets side effects from treatment, who suffers a stroke or a heart attack, but who's relatively unaffected by that, fortunately. And the time trade-off method is the option A for that health state. And you ask somebody, the computer program went through that process by saying, are you willing to trade off 3 years of life to be healthy in terms of avoiding that health state option A? And in this instance, the patient is saying, yes, I'm willing to trade off 3 years of life for that to be in that health state. You then alter that preference to say 7 years, and then they say, well, actually, I'm not willing to trade off 7 years. And it's until they're in equipoise they can't decide between the two options. That gives you a quantitative value for that state of health for that patient. And we simply repeat that process for the other 11 states of health. It seems like a long time, but it took about half an hour, 35 minutes for the patient to go through that process. The computer then individualizes their prognostic risk from the cardiovascular, the Framingham risk function we used, and then incorporates those preferences. So it's a highly quantifiable, but it's also a highly personal way of coming to a decision about whether you should accept treatment or not. And we did this randomized trial about 15 years ago, and it was published in the BJGP, I'm glad to say. So that's the option that will ultimately happen. The patient doesn't see that. They just say, your recommendation is either to accept or decline treatment. So what did we find? Well, we found that actually the decision aid in this form of decision analysis reduced a metric called decision conflict, which is a well-recognized, validated metric to show that people are happy about the decision they make. It didn't increase their anxiety, so going through this process didn't make them more anxious or concerned about what was going to happen to them or not. It increased their knowledge. But interestingly enough, it didn't have any effect on treatment decisions, both for the decision analysis arm and we also had another arm, video information and leaflets, so just giving them information. So you can see roughly 2/3 of people in both arms decided to take blood pressure lowering drugs. What was more interesting from our point of view was around the discordance of what people were saying or what they were being recommended to do in terms of this decision aid program. So you can see the two columns, the shared decision-making recommendation of being treated, 19 or 20% of people who the decision aid said, from your probability of getting a stroke or heart attack and from your preferences, you should start taking treatment. Still 19 people declined and didn't take treatment. And even more surprisingly, in those people in whom the decision aid said you shouldn't take treatment from your preferences and probability risk, 26 people did take treatment. So the discordance from the decision aid was nearly half. So I'm not demonstrating my most successful research to you today, but I think that's the truth of the way research can sometimes fall out. You make assumptions about things and they don't always work out the way you anticipated. We then went on, a la the Lancet comment around the NICE guidelines, and looked at the health policy rationale behind absolute cardiovascular risk estimation in hypertension guidelines. And we did something called a Markov Model, which is, instead of estimating individual risks, we modeled it on a cohort of patients using a Markov process. So the decision model is a little bit more complex, and it's as if you're following this group of people up over a period of 20 or 30 years, modelling. They'll all ultimately be dead, because that's what happened to us all, but modelling them transitioning through those states of health as a consequence of being on blood pressure lowering drugs. We incorporated values from real patients into this model. And we showed that NICE and all the other hypertension guidelines out there generally have got it right. So for people, as you can see on this graph, who are high risk, whether they're men or women, the marginal cost effectiveness, it's almost more effective to treat people and less costly to treat people if you're a high-risk person. So that's somebody over 10%. So the recommendation is correct. For those at lower risk, both men and women, you can see it's really about how willing you are to pay for lifelong treatment in terms of recommendations. And I guess in terms of low-risk people, it's people around my age in their 50s, mid-50s, mid to later 50s, where for low-risk people, it's most cost-effective. So what did that say about use of evidence in clinical practice? So first of all, I think MacKenzie would have approved because appropriate study design is important in terms of matching the clinical question. I think we showed that evidence is necessary but not sufficient. And that's really important in relation to patient preferences because they often do not need and do not follow what you think will happen in real life. And although there's been a plethora of decision aids out there, even when you go through the very formal process with a patient around a decision aid and get them to go through that process, they can still make what seems to be an irrational choice. And we're all slightly irrational, I think you'd agree. Okay, so that's the first issue in relation to the use of evidence. The second one is around the importance of clinical observation that MacKenzie wrote about. So he wrote, opportunity must be had of seeing disease from its onset until its end. Out of the mass of symptoms, those that are essential only are recorded. So as the President has highlighted, we have an interest in our research group on clinical prediction rules. These are clinical tools that quantify the contribution of history, symptoms, signs, and diagnostic tests. And they stratify people according to the probability of a target disorder. And the outcome can be either in terms of a diagnostic issue, a prognostic issue, or treatment or referral. So those Framingham risk scores are actually formally a prognostic clinical prediction rule. Probably the most famous one of all is the Ottawa Anchor Rule, which is a diagnostic clinical prediction rule. And the Ottawa Anchor Rule is something I use in my practice all the time. So if somebody comes to see you, often a young person who's doing a sports-related activity and they have an ankle injury, you can actually ask them focus questions and do a focus exam to rule out confidently the likelihood of them having a fracture and needing an X-ray. So if they are able to weight bear either at the time of the injury or in the consulting room, and if they don't have point tenderness over the medial and lateral mid-foot area, mid-ankle area, you can confidently rule out a fracture, and you do not need to send them in for an X-ray. So clinical prediction rules go through 3 stages: the derivation, where you derive the covariates or the explanatory variables that make up the rule; validation, where you test that rule in a separate population to see if those explanatory variables or clinical variables are robust and remain the same; and lastly, an impact analysis study, where you do a randomized trial usually, or a cluster randomized trial, where you assess the impact on either the process or the outcome of patient care. So the Otto ankle rule is a very good example of that, where they went through the process of deriving the rule, validating it in A&E departments in Canada, and then they did an impact analysis study where they applied the rule in A&E settings, and they showed that by applying the rule in clinical practice, it reduced the unnecessary X-ray rate by 40%, and there were no ankle fractures missed because it had a very high sensitivity. So if somebody tests negative, you can confidently rule out an ankle fracture. So to go back to MacKenzie, he obviously wrote voluminous amounts around the field of cardiology, but I've just picked on the clinical issue of appendicitis. And MacKenzie wrote, if we take a common complaint like appendicitis, there are certain signs which are held to indicate the presence of disease. When only a few of the symptoms are present, appendicitis may simulate numerous other complaints. So when I was working in Oxford in the early to mid-90s, Ian Chalmers set up the UK Cochrane Centre. And this is my favourite quote of all time from an academic point of view. Science is meant to be cumulative, but researchers usually don't accumulate scientifically. So we did accumulate scientifically around something called the Alvarado clinical prediction rule for appendicitis. And its acronym is called the Mantrel score, or the Alvarado rule, after Dr. Alvarado, who derived the first rule in the 1980s. So it's a clinical prediction rule and a decision rule. It facilitates the diagnosis of acute appendicitis and its immediate management, and it's based on a derivation study of 305 patients in an A&E department in the US. So that's the summary of the rule, and you can see it's really more of an accident emergency rule than primary care, because it relies on available blood tests as well. But albeit, it's still useful for the clinical setting of primary care. And you can see it's stratified into 3 risk scores, low, medium and high risk, in terms of either discharging or allowing somebody to go home, observing them, or bringing them straight or very quickly to surgery for appendicitis. We then looked at all the validation studies across the strata of children, women and men. And this forest plot shows that there's systematic overprediction of the Alvarado score for women and for children. But it's accurate for men, both for low-risk patients, intermediate risk, and high-risk patients. So again, it accumulates the evidence in relation to this clinical prediction rule, and shows that actually it's of reasonable value in men, but you have to be cautious in its implementation in children and in women, because it systematically overestimates risk. What did we do next then? Well, again, influenced by Archie Cochrane. His famous quote, "It's surely a great criticism of our profession that we've not organised a critical summary by specialty or subspecialty, adapted periodically of all relevant randomised controlled trials." Well, we all know what happened since the 1990s and the establishment of all these Cochrane centres. Cochrane is undergoing a challenging time at the moment, but I still fundamentally think it is a very worthwhile organisation. So what have we done in relation to prediction rules? These are forms of observational research. We have, we were mindful of, this is the late Chris Szilagyi, who was at Oxford when I was there. Chris set up a register in the early 90s of randomised trials that relate to primary care and general practice. So we tried to reproduce this work in developing a register of clinical prediction rules that are relevant to primary care. And that's what we have done. We've got a search strategy, a validated search strategy, and we've now got over 1,000 clinical prediction rules that relate to common problems in primary care. So examples would be the ABCD rule for stroke, the CHADS-VAS risk score, the centre score. We've done some systematic reviews around that, and we were working with Mark Abel, who was a Fulbright fellow in our visiting last year in our department, to, if you like, disseminate this through his essential evidence platform. So I just want to take a small drop of water if I could. The third area where MacKenzie was prescient was in relation to the systematic approach and use of evidence in terms of clinical care. As he said, as he wrote about in the St Andrews inaugural lecture, systematic documentation of care and examining its impact on patients' health was the rationale behind setting up the Institute in St Andrews in 1919. This is a Gilray cartoon, which I quite like. It's called Death May Decide When Doctors Disagree. So you can see the three doctors with their potions fighting amongst each other. Britannia's not looking too good whilst death quietly creeps up behind her. Okay? So what we are interested in relation to the systematic documentation of care is around medical practice variation and appropriateness of care. Again, I didn't come to this through my own thoughts. It was very much driven by John Wenberg and colleagues in Dartmouth in the US, where they examined the use of procedures, particularly initially in men, prostatic symptoms, and found, lo and behold, that the intervention rate for prostate operations was much higher in areas where there were urologists. So it's all around supplier-induced demand. Okay? So broadly speaking, in terms of clinical practice variation, there's three domains you need to consider. Effective care. This is interventions where the benefits far outweigh the risks, and any variation is really generally a matter of underuse. On the other extreme, there's supply-sensitive care, where the frequency of clinical activities relate to the capacity of the local healthcare system. And Wenberg and the Dartmouth people realised this because in the US, of course, it's a very hospitalist-driven system. And they realised that there were huge disparities in healthcare utilisation, and they often mimicked where there was hospitalists in particular areas doing a lot of procedures. But then there's preference-sensitive care, and these are areas where there are several accepted options available, and actually the use of the interventions is very much in the context of shared decision-making between a patient and a health professional. So this is an example of low variation or effective care. So, for example, clinical examples, if you fracture your hip, well, you need to get your hip fixed, whether that be through hip replacement, a prosthesis, or through a screw and plate. Similarly, colectomy for colorectal cancer. So these are very good examples of effective care. And so there's much less variation, as you can see on the right-hand side. On the very far left-hand side, there's examples of really supply-sensitive care, very high variation. We've talked about prostatectomy, but also things like lower extremity bypass grafting and stenting for peripheral vascular disease, and, of course, stenting for coronary artery disease as well. And somewhere in the middle, hip replacement is probably not the best example. In fact, knee replacement, I think, is a better example of preference-sensitive care, where there are different options in relation to the types of procedures that people are willing to take and the evidence to support those procedures. Of course, I don't do, I do a few minor procedures, but I'm not really particularly interested in surgical procedures. What we were interested in our research group was around ambulatory care-sensitive conditions. So these are conditions that account for about 20% of emergency hospital admissions, and they are conditions where effective outpatient treatment could reasonably prevent hospitalisation. And you can see what they are there: urinary tract infection, pulmononephritis, pneumonia, COPD, heart failure, diabetic complications, angina and dehydration, very much in elderly patients. So we were interested in looking at and finding out about what the variation was in Ireland, and whether that variation has changed or remained the same over time. And lastly, we were interested in those areas where there was very high healthcare utilisation, in other words, there was high admissions for ambulatory care-sensitive conditions. What were the explanatory variables that were driving that high utilisation? Were there demographic factors, patient factors or indeed health-based system factors, supply of GPs and supply of geriatricians. So what we found, these are all the 7 conditions, and on the bottom left you can see all the ambulatory care sensitive conditions combined. So green is high utilisation, lighter green, and white is lower utilisation. You can see graphically there's actually quite a bit of variation in Ireland for the ambulatory care sensitive conditions. And these are the dot plots showing much the same thing. These are health regions, not hospitals. So again, about 16 or 17 health regions, showing that actually there's quite a lot of variation, even in a small country like Ireland. Did it vary over time? So this is the example of angina. Well, it actually remained pretty consistent over time. So if you have a condition where there's moderate or high variation, that seemed to be persistent over those years of from 2012 to 2016. And this SCV is the standard coefficient of variation. It's the net metric. So anything over 0.05 shows high variation. So even for something like admission with angina, chronic stable angina, there's quite high variation. But most importantly, from our point of view, we wanted to look at those across all ambulatory care sensitive conditions, what was driving or what was explaining high variation or high utilization in those regions where there was a lot of admissions for ambulatory care sensitive conditions. And we showed that it was rurality. So if you're a person living in a rural area, you're more likely to be admitted to hospital. GP density. So if you're in an area where there's fewer GPs, more likely to be admitted for an ambulatory care sensitive condition. And a less but still significant association that if you're in an area where there's more geriatricians in the hospital, you will also be more likely to be admitted to hospital. So this is work that we haven't published yet, but we think it's a reasonably compelling argument for the gatekeeping role of general practice. So prevention of ambulatory care sensitive conditions, 20% of all admissions to hospital. So MacKenzie wrote, and this is really around therapeutic decision making. And again, it was interesting reading MacKenzie's work. Obviously, digitalis is commonly used then. But in terms of what we are able to use in our armamentarium of drugs now, it's a completely different world. He said, though, he still had an appreciation about the likely benefits and risks of treatments. He says, is the patient likely to recover without treatment? If so, then the treatment is unnecessary. So he had a keen sense, as we all do, about the benefits but also the potential harms of treatment. Interestingly enough, this is another Gilray cartoon about vaccination. And this is suggesting, of course, that if you get the cowpox vaccine, all sorts of horrible creatures will appear on the area of vaccination. But again, it just shows you that the public were aware about the benefits and risks of any intervention they give. So, the medicalisation of old age. Shah Ibram was a colleague of mine in Bristol. Shah, very, very able and bright epidemiologist, geriatrician. He wrote this editorial in the BMJ about 15 or 16 years ago, where essentially he celebrated and said we should not be apologetic about medicalising old age because it produces many, many benefits for people. And of course, Shah, he's absolutely correct. However, we all are generalists and we all have to deal with the consequences of people being on lots and lots of treatment. And this is data from the General Medical Service card holders in Ireland from 1997 to 2002, 2007 and 2012. And you can see across all age groups on the x-axis, once you get to a certain age, you are very likely to be taking multiple medical treatments. By and large, that increase in drug utilisation has occurred across all the ATC drug classes, as you can see. I mean, you probably can't read all those, but you can see that for most drugs, there's been a substantial rise in the last 15 or 20 years in relation to all classes of drugs. The consequences in terms of polypharmacy, people taking 5 or more medicines. In the Irish population there on the top left-hand corner, sorry, your top right-hand corner, 60% of people in Ireland who are over 65 take 5 or more medicines. And 20% take 10 or more medicines. These are 2012 figures, so the figures have probably gone up since then. So what's the consequence of that? And we got interested ourselves in these metrics that have been developed by colleagues in University College Cork, geriatrician and pharmacy colleagues. And these are criteria based around beers, I know Tony Avery gave a MacKenzie lecture a few years ago, and the college have got their own metrics in relation. They're all reasonably similar and are, if you like, domain or country specific. And so these are the ones that we use in Ireland because they are developed by other Irish researchers. The stop and start criteria. So these are process measures that are consensus based. And there are 80 criteria now in terms of errors of commission. These are issues where the harms of the drug may outweigh its benefits. And then the start criteria are issues where are situations where there are errors of omission, where the condition the patient suffers from would be overwhelmingly benefit from being started on particular evidence-based treatments. So we looked at the potentially inappropriate time trends prescribing in Ireland during that time from 1997. And in fact, there were some improvements. So you may or may not be able to read that on the your left-hand side. You can see the prescription of high-dose digoxin has fallen during that time. Similarly, the prescription of higher-dose aspirin has fallen during that time. So some good prescribing habits have occurred during that phase, during that time period. Unfortunately, there are also been increases in prescribing. So you can see that maximum dose proton pump inhibitors are prescribed to over a third of the Irish population, elderly population. Similarly, it's been very hard to stop the prescribing of duplicate drugs, and similarly that the prescribing of long-term non-steroidal anti-inflammatories and long-term benzodiazepine drugs have also remained fairly static. So you may not be able to read that slide. So the point estimate or the prevalence estimate, so about 5% of Irish patients were taking long-acting benzodiazepines, 16% were taking a maximum dose PPI, proton pump inhibitor, 8 or 9% were taking long-term non-steroidal anti-inflammatory for greater than 3 months, and duplicate prescribing was in the range of 3 or 4%. So these are not insignificant issues in relation to treatment burden for patients. What's driving that? Well, I've said already, the number of drugs you're taking. Okay, so polypharmacy. So we were interested, as I said, these criteria were process-driven. So there was really relatively little data around the outcome of care or the impact on patients. So the first thing we wanted to do was look to see what the impact was on individual patients. And we used a cohort that's been established in Ireland called TILDA, the Longitudinal Study of Aging. So it's a cohort of about 8,000 patients. And we looked at both healthcare utilisation and measurements of frailty in the TILDA population. And for the stop and start criteria, you can see for emergency department visits, both errors of omission and commission are associated with increased healthcare utilisation in the form of emergency admission during that time. Moderate but important and statistically significant impact. Similarly, healthcare utilisation amongst GPs has also increased, both for stop criteria drugs and start criteria drugs. So again, these aren't huge odds ratios, but they are important odds ratios because it does show that people are more likely to be going to the doctor or GP if they're not treated appropriately, both in terms of errors of omission and commission in terms of prescription drugs. And lastly, both stop and start were associated with, start drugs, errors of omission were associated with increased frailty and functional decline. So we were then interested in saying, well, how can we improve the quality of prescribing in Ireland? So the first thing we did was we looked at the scatter, and that's a funnel plot of all the practices in Ireland, 2,500, to see whether, if we were planning intervention, we're going to give an intervention to the people who are, if you like, the less able prescribers. But in fact, what we found was, you can see that most practices within 2 standard deviations, and nearly all of them are within 3 standard deviations. But when you did a regression model and adjust for all factors, there was relatively little variation and potentially inappropriate prescribing between GPs in Ireland. And the majority of variation was being driven at the patient level. And what was driving that was polypharmacy. So all the other cofactors that you might think were important, when you adjust for them, it's the number of drugs you're taking is the main driving factor. So when we were thinking up our intervention, we decided, we thought this was evidence that we didn't need to target high prescribers as such. The issue was more around general polypharmacy, and it was a common problem for all GPs in Ireland. So what did we do? We did a randomized trial in the Leinster area, in the Greater Dublin area, which was based on 3 elements. First of all, academic detailing with a pharmacist. So we worked with pharmacy colleagues who gave a tutorial session with the GPs in the practice around PIP drugs and what they are, what you can do about them, and how you might improve your prescribing. Secondly, we then recruited patients, and we did we got the GPs to do a medicines review based on web-based treatment algorithms on potentially inappropriate prescribing, so that they have both information around the patients who are on these drugs, and they're armed with recommendations, evidence-based recommendations to reduce prescribing in those patients. And then the third element of the intervention was we gave a patient information leaflet so that patients understood what was going on. We had a comparison group, which was usual care, but we also had a non-randomized contemporaneous national cohort as a second comparator group. So this is an example of what the intervention looked like for a GP in the practice. You'd have this is an example of 3 patients in that practice who were, say, the patient number 15 was on maximum dose PPIs and non-steroidal anti-inflammatories over 3 months. Second one was on benzodiazepines, and the third one was on benzodiazepines and non-steroidals. And so they would bring that patient in for review, go through the management algorithm with the patient, and then conclude that repeat prescribing consultation. And that's just an example of the evidence-based recommendations we spent a lot of time generating in support of this trial. So what did we find? Well, initially we were very pleased because we substantially reduced the odds of potentially inappropriate prescribing. And that was both for the randomized comparison group, the usual care group, but also when you compared it to the national sample as well. So we were slapping ourselves on the back until we looked at the drug-specific PIP metrics. And of course, what was driving that benefit was that people were reducing maximum dose PPIs very well. But unfortunately for other potentially inappropriate drugs, long-term benzodiazepines, maximum dose or high-dose non-steroidals over 3 months, and therapeutic duplicates, we didn't make any impact at all. So again, a sobering and realistic estimation of how sometimes research doesn't go quite the way you plan. So this is the end of the third section, and I think that MacKenzie would hopefully approve that a systematic approach to clinical practice and use of evidence enables monitoring and critical reflection in relation to patient care. This is a particular challenge for us as doctors in the 21st century because of medicalisation and appropriateness of care, because we have got such an armamentarium of drugs to offer patients. And lastly, I think a systematic approach enables is an enabling method or vehicle for evidence-based interventions. So, in conclusion, I thank you very much for giving me the honour of giving the James MacKenzie Lecture this year. I've made presumptions about MacKenzie in terms of his writing and applying it to the research we've done, but I hope that I've convinced you that evidence still matters in general practice. Thank you very much.
Thank you, Tom, very much for an exceptionally clear lecture. I really related to that because it spoke to me as a working GP, particularly in relation to hypertension. I love the references to James MacKenzie. James MacKenzie was an absolutely brilliant polymath. Wherever he went, things happened. He was a great leader, but a clinician. He made his name because of diagnosis. I love the concept of decisional conflict, because I realize now what's been happening every time I try and talk to patients about statins and lots of other drugs. But actually now I can put a name to it, But it confirms the importance of research in, messy life general practice. That's how it is. But you can do research. That's what you've shown. And as somebody who uses the stop-start criteria in practice, I think that's very, very important. But also learned that the importance of managing high-risk patients appropriately, because you said in your lecture that effective variation is usually due to underuse of appropriate treatment. I think that's a very important lesson for us. As a commissioner, I'm very interested in ambulatory care conditions that are sensitive to interventions and, of course, polypharmacy. But most of all, I think you have given us a model for modern-day clinical practice, which is the lovely graph that you showed, or the diagram, which is utilizing your clinical experience, the patient's values and expectations, and best available clinical evidence. There's nothing better than that. And GPs, I think, have that wisdom to integrate the three aspects very much. So, Tom, you have shown us convincingly why evidence still matters to general practice today. Thank you very much.